So thanks very much for giving me the opportunity to tell you a little bit about Parkinson's and what we're doing in Oxford to tackle this condition. I'm a neurology consultant leading the medical Parkinson's service at the John Radcliffe Hospital, and I've been helping to look after people with Parkinson's for the best part of 22 years since I qualified as a doctor. And I've been leading as a consultant management and helping people with Parkinson's for about 10 years. And I'd like to start this talk with a short video. What I'd like to do in the next 15 minutes is to give you an outline about the main issues facing people with a recent diagnosis of Parkinson's, tell you a little bit about what the Oxford Parkinson's Disease Centre cohort is doing to tackle these issues, talk about some recent innovations and the use of cutting-edge technology and the global expansion in internet and mobile phone use, and how we can actually use this to measure Parkinson's progression and fluctuation, and to also to harness technology to develop better personalized treatments for individuals. And lastly, to just briefly talk about how research might be used to prevent people at high future risk of developing Parkinson's from actually developing that condition altogether. Many patients in my clinic, when I just have to give them a diagnosis of Parkinson's, as well as the questions in the video, have other issues that they want to raise. And they ask whether their memory or thought processes will be affected as part of their Parkinson's. They want to know what treatments are available and what side effects and what their individual response is likely to be. Most importantly, they want to know about the future. Are they going to still be working in 5 years? Are they going, if they're young, to be able to look after their family and provide for them? Or are they going to be in a wheelchair? And they want to know about the role of exercise and supportive therapies and complementary treatments for Parkinson's. And most importantly, they actually ask when they're going to see me next. So one of the barriers to actually giving an individual who's just been diagnosed with Parkinson's an idea of the future is the fact that our caseload, or people with a diagnosis of Parkinson's, is increasing. And the main reason for this is our population is aging. And what you're seeing here is the number of people in an active caseload in Oxfordshire. So it's about 1,000 people, and how that's grown in the last 4 years since we set up a Parkinson's specialist nurse service. So these are individuals in Oxfordshire, population of 550,000, known to our specialist nurse team. And of course, one of the other barriers is the fact that the NHS is struggling to cope. It is struggling to cope, as you've heard from Sarah, to deal with acute delirium, increased age of average admissions, and the ageing population. And therefore, it may be that an individual with a new diagnosis of Parkinson's will only be able to see their consultant once a year. And in that 20 minutes of a clinic slot, how can I properly assess their Parkinson's in the previous 12 months? So this is really the challenge. So the OPDC cohort was set up 4 years ago, and it is supported not just by Parkinson's UK, but by the Oxford BRC and Dendron, which is part of the National Institute for Health Research. And our vision really is to identify the earliest changes that lead to Parkinson's in at-risk individuals, ultimately to prevent the development of motor onset Parkinson's. But we're also very involved and passionate about developing biomarkers from the clinical cohort that will diagnose Parkinson's at an earlier stage when treatments will be potentially more effective, and also to prognosticate, so biomarkers that will tell someone just diagnosed where they will be 5 years hence. And these research themes interlap with 3 other close themes in OPDC. One, to develop better cell-based models of Parkinson's, a model in a dish, shown here from dopaminergic brain neurons taken from a simple skin biopsy from a patient in an outpatient clinic. and also to develop better relevant animal models of Parkinson's from rats and mice. About 8 years ago, from very humble beginnings, I got a very small innovation grant that I think was about £14,000 to look at barriers of access to care for people living in the Milton Keynes community where I was then working, to coming to see a specialist for their Parkinson's. And we were able, or my research nurse was able to go into all of the GP practices and identify people living in the community with Parkinson's. And we found that 90% of them were known to a specialist and were receiving that input from either a specialist nurse or a hospital consultant. And what we then did within OPDC was to roll out this model to the Thames Valley population of 2.1 million. And one of the strengths of the cohort is that it is truly representative of Parkinson's as we know it. It does not have a bias of many national centres where you're recruiting much younger patients, more severely affected, or possibly those with a stronger family history. And so far now, 5 years on, we've recruited our 1,000th person with early Parkinson's to the cohort. And nearly all of our controls, who are largely family, friends and relatives, what we call spousal controls of people with Parkinson's. And we're particularly interested in looking at the earliest pathways to Parkinson's through our at-risk group. And increasingly, we're looking at people who are brother or sister of someone with Parkinson's, but also people with a sleep disorder called rapid eye movement sleep behaviour disorder, or RBD. And I'm going to tell you why that's so important in a few minutes. The main message of this busy slide is that a person comes up to the clinic, they don't have to travel very far, because we go to them, we go to the 11 hospitals, and they, with the consent and blood test, the whole visit is 2 to 3 hours. And because we're looking at how Parkinson's progresses and differs from one individual to the next, we're particularly interested in following people up longitudinally. So people with Parkinson's and those at risk are now being seen every 8 months, up to a total of 10 years for our cohort. So this really is one of the biggest and best well-characterised cohorts of Parkinson's in the world. And what we're able to do in OPDC is integrate a wealth of information, hear from somebody with Parkinson's, where we're able to collect clinical information on their motor function, on their non-motor and memory function. We can do, in a subgroup of people, brain scanning, skin biopsy, blood test biomarkers in all, and DNA, so your genetic code, and how individual differences might increase your risk of getting Parkinson's. So I'd like to just give you 4 key findings that we've developed over the last 4 years from our cohort. And the first, taken from the first 650 people with Parkinson's, is that age remains by far the biggest predictor of whether you will get Parkinson's in the first place and of how you will be affected in the first year. The older you are, unfortunately, the worse you are. Parkinson's affects 1 in 500 people in Oxfordshire, but 2 to 3% of those over the age of 75 years. The other thing is that whether you're male or female will influence how your Parkinson's manifests. Men tend to have a more symmetrical upper body Parkinson's, women having a more lower body Parkinson's with early balance and gait problems. The second thing is that sleep is highly relevant to Parkinson's, and individuals who have early Parkinson's, up to 50%, will also have this REM sleep behaviour disorder. And if you have Parkinson's and RBD, you have more memory problems, more sleep issues, and more low mood. And we also are interested in translating our research to the bedside. So we're interested in developing simple screening cognitive tests that take only 10 minutes to administer. And what we were able to show is that the Montreal Cognitive Assessment was much more sensitive than the older MMSE version in picking up early memory problems in Parkinson's. And lastly, we've been able to show that functional brain imaging, not structural, can distinguish 90% of early Parkinson patients from controls replicated in a separate validation cohort here, and that these changes or altered basal ganglia connectivity in this network actually normalize when a person with Parkinson's is given dopaminergic treatment. So the next phase is to scan a much larger number of people and to see whether this network predicts progression 5 years later. As Parkinson's progresses, one of the main issues that really bothers patients is the unpredictability and the symptom fluctuation. And this is because as the Parkinson's progresses, then the window in which the medication works becomes narrower, and people experience wearing off periods or excessive movement. And what we're doing in Oxford is working with mathematician Max Little to pilot low-cost, innovative technologies. And you're seeing here a 6-minute mobile phone app that if you have an Android phone, I can email to you later as an app. People can then do this at home 4 times a day over a week. And in 6 minutes, it can capture your manual dexterity and reaction time, your ability to walk and standing balance, your tremor, if you have any, whether holding the phone out or resting it on your hand. And it can do a simple voice recording. Now, when Max has piloted this in a very small subgroup of 20 Parkinsons and 20 controls, he can actually separate or tell on a blinded way 99% of people with early Parkinson's from controls who are age-matched. So the question now is, can we use this technology potentially to population screen large numbers of at-risk people without them ever having to come to a clinic? Furthermore, this actual test can predict your Parkinson's motor severity. So we could use an internet database of people who've consented with a diagnosis of Parkinson's that we need a particular level of motor severity. They can do this test online without having to come near a clinic, and we can predict their Parkinson's rating scale from it and recruit them directly to drug studies. So I think this is the future of healthcare, and it needs to move with the times. What about preventing Parkinson's altogether? We know that by the time motor symptoms first manifest, such as tremor, difficulty walking, voice changes, the processes in the brain have been going on for at least 15 years beforehand. And one of the strongest risk factors now emerging is REM sleep behavior disorder that you're now seeing in this video. And typically, the person who has REM sleep behavior disorder doesn't have a problem. It is the bed partner who's getting woken up by this vicious dream enactment, terrible nightmares, and having a black eye, or the person falling out of bed. And during normal REM sleep, we lose our muscle tone, and that protects us from this type of behavior. During REM sleep behavior disorder, the pathways that block muscle tone during REM sleep are abolished. And this leads to this very disabling problem. And as a worst case scenario, I've had a patient who fell out of bed, knocked her eye on a corner of the desktop, the bedside table, and detached her retina and went blind. So what I'm now telling people is that, firstly, if you have REM sleep behavior disorder and Parkinson's, look at the environment, remove hard obstacles, but it is treatable with melatonin or clonazepam. The point here being that if you have REM sleep behavior disorder and other non-motor features such as impaired sense of smell or constipation, your lifelong risk of actually getting Parkinson's or a related syndrome is 82 to 92% if we wait over 10 years. So this conversion is far higher than any of the known genetic risk factors that we have for Parkinson's. And we really need to be doing something for these individuals because of their high risk of future conversion. So we've now started a cohort of RBD through Harry Walensky, shown here, who valiantly drives to, Papworth, Sheffield and Oxford, to the sleep clinics. And he, in this cohort of about 70 people with RBD, compared to Parkinson's and controls, has shown subtle motor abnormalities in RBD subjects that are not yet bad enough to be Parkinson's, and a very similar level of non-motor symptoms to our early Parkinson's. So we believe that RBD subjects are effectively early Parkinson's or prodromal. So what about the future for Parkinson's research? I think that earlier diagnosis in the premotor phase for RBD subjects remains one of the best chances of a cure for Parkinson's. And that is really interrupting this. So the path from so-called idiopathic RBD to Parkinson's. individual tailored treatments are now becoming possible and certainly will be over the next decade with technological advances and innovative approaches. Better monitoring of Parkinson's symptoms and progression should enable us to develop better symptomatic treatments from our cell-based models and the other animal models we have in OPDC. But lastly, effective research has to become more collaborative. And with patients such as RBD, because they're quite rare and they need a lot of sleep clinic diagnosis to be given a formal diagnosis, we are now part of a pan-European initiative to combine these patients to actually start to move towards developing treatment strategies that would modify the progression. I'd like to end by just thanking the team. Firstly, the patients with Parkinson's who very much volunteer in an altruistic sense their time and energy to take part in our research. The Dendron research nurse team, the clinical fellows and our collaborators, including Sam Yvetz, who is our biobank curator. Thank you.